Namaskara, greetings to everybody. My name is Dr. Karthik Agoram. I teach biology, mainly cell biology and biochemistry to undergraduate students. Today, I have the great pleasure of speaking with a great expert, Dr. AJ Vinaya Simha, an endocrinologist at the Mayo Clinic in Rochester, Minnesota, United States, about one of the most common yet complex maladies that afflicts millions of humans, and that is diabetes. So thank you, Dr. Simha, for giving some of your precious time and sharing your knowledge and expertise with us.
Oh, thank you, Karthik. This is. Um, I hope you haven't forgotten me. So there is absolutely. In some ways, I'm flattered. In some ways, I'm a little alarmed. Okay, so this is. I thought this was just a friendly banter. Okay.
Vinay, and I go way back. We attended primary school, high school, and pre-university together in Bengaluru, India, and then went our own ways in 1987. And we were not able to stay in contact for all of these decades until a few years ago. Thanks to WhatsApp, we got back in touch. Before we get into the topic at hand today, Vinay, I'm very curious about your journey. You know, sort of your journey from MES College for pre-university to the Mayo Clinic. But before we even get to that, um, can you tell us what an endocrinologist is? What do you do? And what are your areas of expertise?
Endocrinology, as you know, is the study of hormones. So endocrinologists are fascinated by hormones and how they contribute to maintenance of body functions and equilibrium and so on. So basically, we try to deal with problems related to the hormones, but the vast majority of what we do is take care of diabetes and its complications. Now, I personally, of course, my focus is on lipids. We try to understand how body fat distribution influences metabolic functions and so on. So, yeah.
Right. So sort of the connection between diabetes and obesity and what I guess these days we call the metabolic syndrome.
Yes, yes.
All right. So how did you choose endocrinology? So if you can sort of take us back to 1987, how did you choose this path?
Well, I don't know. Well, after 87, I did my MBBS at Kasturba Medical College, and just wanted to be a doctor for whatever it was worth. All those, when you're young, you're so stupid. And then anyway, so I did that and then stumbled along. But then, after I finished my medical school in '92, so then I did what I thought would be a brief stint at the All India Institute. So I wanted to study a little bit more human physiology. So I joined there. And then, so that's when I got introduced to this topic of insulin resistance, especially insulin resistance in Asian Indians. So, and that was fascinating. So why do Asian Indians, despite not a high burden of traditional risk factors, no smoking, no obesity, have this very high burden of cardiovascular disease, diabetes, and so on? And so I happened to get acquainted with somebody who was doing some, at that time, cutting edge measurements of insulin resistance. We started doing glucose clamp studies and so on. So that's when I really got interested in insulin resistance. So we tried to do a small project on yoga and insulin sensitivity and so on. So yeah, so it was meant to be a 6-month, 1-year thing. So then I spent 3-4 years at the All India Institute. Okay. And then after that, I moved over to the US and did my residency, which I had to do to become an endocrinologist. Right. And then I did endocrinology fellowship at UT Southwestern. And then, well, I've been now at Mayo Clinic for about 10 years. I've survived 10 winters in Minnesota. That's how I keep track. Okay.
So that's really fascinating, and I want to come back to the yoga and insulin resistance connection at some point today. I'm glad you mentioned that because I was really not aware of these research projects, and I think we will all benefit from knowing a little bit more about that. So maybe we can get to sort of the topic at hand today, which is diabetes. So we all turned 50 a couple of years ago, and for some of us, this half-century mark came with some gifts. Like a lab report and some warnings of pre-diabetes or diabetes that our doctors shared with us. So having been one of those people who was handed that gift, I went to the internet, like I'm sure many of us did. We asked people for advice, and just any information on how to manage diabetes, because it just seems like such a daunting condition to deal with, and it's not something that you can deal with for 1 or 2 years and you've cured it and it's gone away. It's almost like it stays with you forever. And then we end up with advice and information that kind of looks like just this. There's so much out there. You don't really know what is good information, what is not. And on top of all this, we have well-meaning friends and relatives who give us all kinds of advice about all kinds of remedies that they may have experienced or somebody else may have told them about. And it all becomes so frustrating and confusing. And I just feel like having someone with true expertise in this area is very important for us all to be able to experience and take advice from. So let's start with the basics, Vinay. What exactly is diabetes? Are there many different types of diabetes? And if so, what are some of the differences among these different types?
So how much time do we have?
That's right. As much as you want,
So,
Vinay. Yeah.
I meant to say, there are so many ways of answering this question. Okay. So in a very simple, the way everybody understands is diabetes is a disease characterized by high blood sugars, which is true. But then it's not just about high blood sugars. Okay. In many ways, now again, I don't mean to get too technical, but my residents, fellow students always know about this. I always quote this one. There's a great, if you look at the history of diabetes, the very famous diabetes researchers. So there was this chap called Minkowski. So what Minkowski did, he was the first one. So he ligated the duct of the pancreas and then caused pancreatic atrophy in the dogs. And then he took the urine of these dogs and he tasted it. And then that was the first time when he said, oh, look, the urine is sweet. So if you don't have pancreatic function, you get glucose spilling in the urine, and this is what causes diabetes. So at Southwestern, so we had a great diabetes researcher, and then he wrote a very telling commentary saying, what if Minkowski was agusic? By that meant if he could not taste it. And if he had just smelt the urine instead of tasting it, then what he would have smelt was actually ketones. So which is something to do with, fatty acid oxidation and so on. So then he would have noticed that, oh, diabetes is a disease with fatty acid oxidation defect. So it's where you can't oxidize fatty acids. But because he tasted it instead of smelling it, he says, oh, he misled us all along. Okay. So people thought that insulin is all to do with glucose and nothing else.
Yeah, and
so
even now we commonly make that association.
Exactly.
So, yeah.
So while it is very true that the hallmark of diabetes is high blood sugars, it's just only one part of the story. So it's a complex metabolic disorder. It affects multiple metabolic functions. One of them is also carbohydrate disposal. So it's a group of complex metabolic disorders generally characterized by high blood sugars and defective insulin action. So whether this defective insulin action is due to absolute insulin deficiency or because of a relative insulin deficiency in the presence of high insulin resistance, that's what determines the two broad types of diabetes. So all of us know that, by and large, there are two major categories of diabetes. So we used to call them as insulin dependent and non-insulin dependent. Again, the purists don't like that. We now say type 1, type 2. Of course, when I talk to my endocrine fellows, so that's too naive. So we have people with like type 3, type 4, and so on and so forth. Okay. But very broadly speaking, so you can get diabetes. A simple form called type 1 diabetes starts with children. So this is because for some reason, the body's pancreatic cells, the beta cells which make insulin, are destroyed. 95% of the time it's because of an autoimmune destruction. And so therefore they just get they're low on insulin. So that is not a lifestyle disease. So there's nothing that these kids can do. They just don't make insulin. They will die if they don't get insulin. So this is type 1 or insulin dependent diabetes. On the other hand, the vast majority of others, the adult onset, is the so-called type 2 diabetes. And this is the one which is associated mainly with obesity, metabolic syndrome, lifestyle, and so on. So here, at least primarily to start with, there is no problem with the pancreas. But then the problem seems to be insulin resistance. And most often this is related to obesity. So obesity in some complex way makes the insulin not work as well. And so the pancreas has to overcome that and has to make more insulin. And then over a period of time, the pancreas gets overworked, gets exhausted, and then you end up with diabetes. So type 1, type 1 absolute insulin deficiency, type 2 starts with insulin resistance, but invariably progresses on to get insulin deficiency as well.
So in type 2 diabetes, one can think of it as when it begins in adult onset, the insulin is made, but your body is not seeing it, so to speak, and is not able to respond to it.
Right. So if I eat a plate of rice and I need like 5 units of insulin to take care of that, somebody with insulin resistance will need 10 units to take care of it instead of 5.
Okay.
So every day the pancreas is making twice as much as it can. And therefore, in a short period of time, it will quit. And that's when they will also develop. So they'll still be making some, but it won't be sufficient.
Got it. Okay. So, so I think the rest of our conversation is going to focus on type 2 diabetes, because that is what you have identified for us as a lifestyle kind of condition that hits, millions of people in their middle age, and some of us have been given that gift, so we can talk about that. So okay, so how many people, just to give an approximate number, in the world have type 2 diabetes? Is it 10% of the population?
Yes,
20%
exactly.
of the population?
10. So most 10%. Epidemiological studies estimate that the prevalence of diagnosed diabetes is about 10%. Of course, it varies from geographical locations, it varies across rural and urban areas, but by and large, yes. So I think in the US, it's about 10%, India, maybe even a little higher.
Okay.
But that's a good rough estimate, about 10 to 12%.
About 10 to 12%. Okay. So that's a pretty high number. That's about 700 million people, if my math is correct. So that's a lot of people who are suffering from diabetes. So you mentioned insulin just a couple of minutes ago, and how that is related to many different metabolic processes. So what does insulin do in our body to then that helps our body process the glucose or process the sugars? And what are some other things that effects that insulin has on our body, so that when you say there's an insulin deficiency, all these issues occur?
Put very simply, so insulin is what unlocks the door of the cell for the glucose to enter. So we eat and the food is broken down, absorbed, and the blood transports it to each and every cell. But for the glucose to actually enter at least some of the cells, not all of them, but the critical ones, fat, muscle, so on, so you require a specific transporter to get the glucose in. And that's what insulin does. So it actually promotes the expression of these transporters. So in the absence of insulin, the glucose does not get into the cells. It just stays in the blood. So you get high blood glucose, while the tissues are actually starved of nutrients. So you have high blood glucose, but then that's it. It's starvation despite the presence of so much nutrients right so close. And then, of course, on the one hand, so the cells don't get enough energy. And on the other hand, the high blood glucose itself has a lot of detrimental effects. So acutely, it can cause dehydration and so on. And of course, in the long run, the high glucose causes vascular inflammation and so on, and so leads to all kinds of complications. So, yes.
So,
now this is, of course, very glucose-centric. This is a very glucose-centric view of insulin. But again, as I said right off the bat, insulin does a lot more than that. Right. So insulin also is a critical player in regulating fat metabolism. So it stimulates. So it's actually the most potent anabolic hormone is
Right.
insulin. So, it prevents the breakdown and promotes the synthesis of fat, synthesis of glycogen, synthesis of protein. So all of these things, it's like a master switch. So in the absence of insulin, so there is just catabolism. So therefore, the body breaks down fat, cannot do it in an efficient manner, ends up making ketones, proteins are broken down, there is wasting, and of course, so glucose is not utilized.
Right. So it's more than glucose, but glucose is sort of one of the most obvious um,
Yes, most obvious
symptoms that
manifestation of
we are
insulin.
manifestations of this. So that brings me to sort of my next question um, is how is diabetes um, diagnosed, and how is these how have these diagnostic tools evolved over time? Because when I was younger and my elders were experiencing diabetes, it was simply a blood glucose test. But today we talk about A1C levels, and so if you can educate us about a couple of different ways that diabetes or is diagnosed, and how these diagnostic tools have evolved over time.
Actually, this is one of the simpler questions in the sense
Okay. Yeah.
I always, I don't know whether I joke or say that I chose endocrinology or diabetes because the diagnosis is so simple. Okay. So it's like there are many other things where, there's a very complicated diagnostic algorithm. So whereas diabetes, on the other hand, is quite simple. If you have glucose over a particular level, we call that as diabetes.
Right.
Now, again, there's a lot of course, controversy about why this number, why 100, why 110, why 125. It has more to do with that's the level that correlates with diabetic complications. So once
Okay.
you have, so again, we're not really chasing a glucose number. What we want to do is to avoid complications of diabetes. And one of the most characteristic complications of diabetes is the diabetic eye disease called diabetic retinopathy.
Right.
And what they found was that the ones who are going to develop diabetic retinopathy, invariably they have a fasting glucose greater than a particular number. And that's what that number is.
Right.
So if you have a fasting blood glucose consistently over 125, then that means that you have diabetes.
So fasting means you have not consumed a meal for say 8 to 12 hours.
8 to 12 hours, exactly.
Okay.
Exactly.
Okay. And then they measure the blood glucose levels. If it is above, I think you said
It's about
120,
125,
120,
126 or higher,
126 or higher.
but you don't want to hang your hat on one single number, so
Correct.
you want a repeated measure.
Correct.
One other way of doing, but then again, it's fasting is a myth. Nobody is actually fasting all the time. So
Right.
really, so what really matters is your the profile of your blood sugars throughout the day.
Right.
But then obviously you can't keep measuring it all the time. Therefore, we got a better measure called the hemoglobin A1C, which really is an integrated measure of the blood glucose. And so here what we do is we measure the glucose that is bound to one of the hemoglobin fragments. Okay, so the hemoglobin, so it's a non-enzymatic glycosylation of hemoglobin. So because it's non-enzymatic, it just simply depends upon the average blood glucose, the ambient glucose that the hemoglobin molecule is exposed to.
Okay.
So
So the
that
more
way,
glucose there is over time, the more glucose will bind to the hemoglobin.
right, and you'll
Okay.
have a higher hemoglobin A1C.
Okay.
So here the magic number is 6.5.
Okay.
So if you have a hemoglobin A1C over 6.5%, or if you have fasting plasma glucose over 125, or you can also do a glucose challenge, which we generally don't do. But then, we can give a glucose load and see how you respond. If 2 hours after a glucose load, if the blood glucose is over 200, any
Okay.
one of these criteria will give you a diagnosis of
Of
diabetes.
diabetes. Okay. Okay. So there are, although it seems very simple, early glucose or diabetes diagnoses were based on simply blood glucose measurements, typically fasting blood glucose. But today we get an integrated measurement with the hemoglobin A1C levels, and the number for that is about 6.5, as would be shown on your charts, and that above that you are diagnosed as a diabetic. Okay, so I think
Actually,
that's
if
great to.
anyway, it's
Mhm.
gotten easier. So when I was a medical student, so we used to do glucose tolerance tests.
Okay.
You would give 75 grams of glucose, measure glucose 30 minutes, 60 minutes, 90 minutes, 120 minutes. And then there used to be criteria. If two of these are greater than something, one of this plus something, we've gotten away from all of that. If
Okay.
anything, it's simplified. I
Okay.
think the controversy is in the actual number. So there used to be a time when people would say, oh, it has to be over 140, then they said 125. And now we have also defined a category called pre-diabetes.
Right.
Okay, so where they say it's over 100, that's where the controversy is. So some people think that, oh, all this is some kind of a deep conspiracy by pharmaceutical companies to move the goalpost, get more people labeled as having diabetes and give drugs. And I don't think we should get into all of that.
Right.
But
Right.
yes, while there is, the whole concept is to identify people who are likely to develop complications.
So the pre-diabetes is a concept which just simplistically we can think of as, if you are diagnosed as pre-diabetic, then unless you take certain measures, then the chances are high that you will develop full-fledged type 2 diabetes.
Exactly. So having pre-diabetes does not mean you're going to get the diabetes complications, at least not the classical diabetes complication of retinopathy, nephropathy, neuropathy. But it has been shown that every year, 10% of people with pre-diabetes go on to develop overt diabetes.
Got it. Okay.
So you need to do something to prevent that progression.
So if you're thinking about the hemoglobin A1C levels, at what level would you diagnose someone as a pre-diabetic?
Greater than 5.6.
Greater than 5.6. Okay.
So normal is below 5.6. 5.6 to 6.5 is pre-diabetes.
Okay. Okay.
Just like fasting blood sugar. So fasting blood sugar less than 100 is normal, greater than 125 is diabetes, 100 to 125 is pre-diabetes.
Okay. So that's, I think it's important for me for sure, and for everybody else who will get to watch this to know those numbers, but not, like you say, hang your hat on a single number. Yeah, but just have an idea of this is what all this means. So thank you for doing that. So I was going to ask you about what are the different problems that high blood glucose and other diabetes symptoms really cause within our bodies, but you already kind of answered those. One is diabetic retinopathy, which is, in simple terms, an eye disease. Nephropathy is kidney disease, and neuropathy is nerve disease.
Yes.
Okay, so those are some of the things. And then you also mentioned dehydration and starving of cells and things like that because of the high blood
Broadly,
glucose.
so that is acute complications, dehydration, ketoacidosis, so
Got
on.
it. Okay.
Chronic complications. So those are things that people can notice. Okay. And so they generally come to attention. But if you have sugars of say 200, 250, often it's asymptomatic.
Okay.
So you don't really get any overt symptoms of dehydration and so on. But we still want to treat them because they can get chronic complications.
Okay.
These chronic complications are what we call micro and macrovascular. So the microvascular is eye disease. Diabetes is the leading cause for blindness in the world.
Wow.
It's the leading cause for dialysis and kidney transplantation, nephropathy.
Yeah.
It's the leading cause for non-traumatic amputations. So that's the neuropathy.
Right.
And way beyond all of this is it's the most important contributor to cardiovascular disease. Right. So people with diabetes are clearly at extremely high risk for heart disease. There is a school of thought saying that, generally the ones who are at highest risk for heart disease is somebody who's already had a heart attack. Okay, clearly what can be worse?
Right.
If you've already had a heart attack, you've shown that you're going to get a heart attack again.
Right.
But if you have diabetes, that risk is almost equivalent to somebody who has established heart disease. So diabetes is considered as a heart disease risk equivalent. Okay, so I don't think it's completely true, but anyway, nonetheless,
right,
they are very, very high risk for heart disease.
Okay, so overall, it's definitely something that someone who's diagnosed with it has to take some action and see if they can, do things to improve their condition. So speaking of that, what are, my doctor told me that if my blood sugar levels reach a certain number, they may have to put me on diabetes medication. So what are some diabetes medications for, I guess, specifically type 2 diabetes, and how do they work?
Well, so as I said, so diabetes is all to do with either insulin deficiency or insulin resistance. So accordingly, you can look at all medications as either promoting insulin sensitivity, like they'll decrease this resistance so that the insulin works better.
Okay.
Or if you're deficient in insulin, then they'll provide insulin. So there are medications which will stimulate your body to make more insulin, or you just give insulin itself. But the first step is not that. So the first step is to try to make you more sensitive.
Okay.
And the best way of doing that is actually lifestyle. Diet and exercise and maintaining the appropriate ideal body weight.
Right.
That is the best way of improving insulin sensitivity.
Okay.
So that's the cornerstone of diabetes management. And after that, we do various medications. So the most common one is something called metformin. And after metformin, there are lots of others. So there are new medications, old medications. I guess it's best for somebody to actually see a doctor and get into the nuances of which medicine works best for them.
Right.
There is no one good best medicine besides diet and exercise.
Sure.
It's all a matter of weighing the risks versus benefits and the cost effectiveness of the different medications.
Right.
But yes, we do have lots.
Right. So maybe, sorry, go ahead.
No, go ahead. Yes.
So one of the things, maybe this is a good time to bring this up. You had mentioned at the very beginning that one of the first things that got you interested in this area was a research project that looked at the connection between yoga and insulin resistance. Can you tell us a little bit more about that and how that might fit into someone's lifestyle?
I mean, clearly it's a lifestyle disease. So now, no expert on yoga or anything. So, I mean, yes. So anything that will promote healthy lifestyles, moderation in diet, regular exercise, relieves mental stress. So that will certainly help. Okay? So it will certainly help, whether it be yoga, whether it be regular aerobic exercise, Tai Chi, whatever. Okay? I think it will help. And so will yoga. Does yoga do it better than other exercises? I don't know. And I don't think anybody has actually studied it.
Right.
So people do all of these things. Oh, you do Paschimottanasana, then your pancreas will get massaged and you will get more insulin. I don't quite believe in that.
Right.
Okay?
Yeah. So
will yoga be beneficial? Absolutely. Okay.
Right.
But then is it something that everybody can do and reproducibly improve everybody's blood sugars in the same way? Probably not, okay?
Right.
For some people, it causes more stress, whereas they probably will get stress relief from listening to music rather than this thing.
Right.
Anyway, what is yoga for that matter, okay? If yoga is, Aurobindo says all life is yoga, okay? So I guess anything well done will probably will qualify as yoga, and that will help. Yogasanas are also beneficial. Okay, I'm not saying that, but they're not a panacea.
Correct.
And I think some things are carried to an extreme, saying that certain poses will stimulate your pancreas, massage your pancreas, and cause.
Right. So the bottom line is physical activity. And if it comes in the form of yoga, it's great. If it comes in the form of someone, walking briskly for 5 kilometers a day, that if that works for them, then that can be just as good.
Absolutely. In this context, let me mention this once. This is a very celebrated study. It's called the Diabetes Prevention Project. So the NIH did this like about 15 years ago. So they took people with pre-diabetes, and I think this is the most relevant thing. Pre-diabetes, that's when you can put the clock back before all this happens.
Right.
So they took people with pre-diabetes, 3,000 people, and they wanted to see how do you prevent diabetes. So a third of them did nothing. They were the control group. A third of them got metformin, which I believe is the best medicine for diabetes. So they already started aggressively treating them with the pill. and a third of them did lifestyle. And this lifestyle group was not anything dramatic. So they exercised for 150 minutes a week, 30 minutes, 5 days a week.
Right.
Then there was just some modest caloric reduction, individualized, and then so they lost about 10% of their weight. Okay,
Right.
so it was not again anything dramatic. Okay, it's about 10, 15 pounds. At the end of 3 years, the prevention of diabetes was 60% in the lifestyle group compared to 30% in the metformin group.
And this was simply walking
Yes, this was simply
for
moderate intensity,
moderate
regular aerobic
intensity. Right.
exercise, 30 minutes, 5 days a week,
Right.
and some small dietary changes.
Right. I think
So
that's
when it
great to
comes
know,
to
and it's very
diabetes,
important for people to be encouraged by this.
yes.
Right.
So this is not just, I'm not saying this simply because it's politically correct. So this is hard science, hard numbers, which show that lifestyle changes are twice as effective as the pill when it comes to diabetes prevention.
Right. So
Which
you
is why,
mentioned there were
unless
three
you do
study
that,
groups. Do you remember how many study subjects there were approximately for the
3,000 people.
3,000 people?
So
You
this is
you
about
mentioned that. So
3,000 people. Yes,
right.
yes.
Okay. Yeah. So this was a large study, very rigorously done,
DPP, the
and
Diabetes Prevention Project. So this is a
right.
often quoted study.
Right.
And I think, yeah.
So that is very encouraging. I think of everything that you've told me today, that is the most encouraging thing that I can take with me. That with moderate exercise, there is a way to get the same effect as you would get if you were on some kind of medication. So if you can avoid that, then with exercise and minor dietary changes, that's wonderful. So
Minor sustained.
sustained, yeah, that is very important. Yeah, thank you for saying that, because we can all go on these crash diets, but 6 months later you're not following it anymore. It's not a good diet. So my students ask me all the time, so what is the best diet? And I tell them the one that you can keep up.
Absolutely.
Yeah.
Absolutely.
So yeah. So now I think I want to change direction a little bit and talk about a couple of controversies that I will admit that these are the things that led me to having this conversation with you. And one of those has to do with the demographics of diabetes. You mentioned before that 10 to 12% of the population has been diagnosed with diabetes, but it may be higher in certain populations, especially the populations that we come from, the South Asian, Indian populations. And I think this is true of both, from what I have been able to read. This is true of both Indians who live in India versus the Indian diaspora that is living abroad. We seem to be more susceptible to diabetes than many other populations, and some papers that I read even called India the diabetes capital of the world. What can you tell us about this, and what may be some reasons that may have led to this point? What are some hypotheses that are out there that might explain why this is the case?
Well, we don't know. But of course, that never stops us from talking about it.
Right.
So, yes, it is certainly true that there is a very high prevalence in Asian Indians. And yes, quite rightly, diabetes, yeah, India may be the diabetes capital. So again, yes, so the hypotheses, yes, all kinds of, so the evolutionary pressure has always been on avoiding starvation.
Right.
It was never about dealing with caloric excess. So that was never a luxury we had. Millions of years, so it was about how do we avoid the next famine.
Right.
And so we had those who had these polymorphisms which would help them avoid that. So primarily people who would store their energy rather than burn it off.
Right.
So they're the ones who seem to have done well over these millions of years and have evolved. But now, unfortunately, that's not an issue. So it's become detrimental. Okay, so we don't need to store, but yet we store.
Right.
And therefore, when we store, there's only so much we can store. Yeah? So there is a finite amount of energy that can be stored on the body. And that's what I told you. My interest is in this group of disorders called lipodystrophy. So these are people who don't have fat. And you think that
Hmm.
if you don't have fat, oh my God, they're so
That's
lucky.
great. Yeah, yeah.
No, they have the most raging insulin resistance and diabetes. Because in the absence of adequate fat stores, all the energy actually goes into these liver, muscle, the other viscera, whose job is not to store fat, but now are forced to store fat.
Okay.
That causes insulin resistance and high lipids and so on and so. That's why we studied them as a model to
Right.
understand what's happening with obesity.
Right.
So,
So,
number one, those who store fat and can't store it well, they seem to be at highest risk. Now, why does that happen? We don't know. We are just trying to understand. Some people believe it has to do with fetal nutrition. So, maternal malnutrition. And then, when you don't have enough of these adipose tissue and muscle tissue, so you're always born with a lower amount.
right.
And so always your storage capacity is low. So later on in life, when you have so much to store, you don't know where to store it. And so
Okay.
therefore you end up storing it in the wrong places. That is mainly in the liver and within the muscle, whose job is not to store fat. But once they have to store fat, then it leads to these metabolic abnormalities.
Got it. Okay. And
That
that
could
is exacerbated by the caloric abundance that we have today, that during the course of human evolution was not the case.
absolutely. So it's
Right.
not that this gene came out this 50 years ago or 100 years ago. So this is
Right.
what we have had all along.
Right.
But we never had this need for excessive storage. But
Right.
now suddenly we are flooded with these. Calories are so cheap. Okay,
Right.
so
Right.
everybody just gets, and then these empty calories, so to say,
Yeah. Yeah.
and that has, of course, brought this problem to the fore. And so it is probably both nature and nurture. So
Right.
we
Right.
are. It's never a debate. I think it's always nature plus nurture.
Right.
We are predisposed to in some, and of course this is extremely naive and simplistic. So people have looked at polymorphisms in genes that have to do with insulin secretion, so on and so forth. It's probably too many things that go into making this, but we certainly know that yes, so those who have maternal malnutrition and who have this abnormal body fat distribution, strong family history, all of these things seem to predispose Asian Indians. And but yeah, so actually Chennai, so there's a very eminent diabetes expert, and he's done this thing called the CUP studies. So the Chennai urban rural diabetes
Hmm.
prevalence studies, and they have shown that even though, I mean, clearly our genes of somebody in Chennai and in rural Tamil Nadu can't be too different. Okay, but
Right.
there is a difference in their diabetes prevalence. They have actually looked at the difference in prevalence in slums and in other sort of populations. So yes, so lifestyle plays a role. Okay.
Right. Right.
But then yes, so there is certainly a genetic predisposition. Do we completely understand? No.
And so the two together is what we see manifesting in the population. So I want to touch upon the diet idea that you mentioned, and um, you know, the big elephant in the room is, of course, especially for us South Indians, is white rice. Right. And it's a lot of hard work, even for me, to avoid white rice. And then we read about
It's also the white
glycemic.
elephant, I suppose.
I'm sorry,
Not
yeah,
just elephant, the white elephant.
the white elephant, yeah. And it's like uh, we read about glycemic index and glycemic load and so on. So I also read something about how our ancestors, although they ate a lot of white rice, they never got diabetes. And all of that is so confusing to me. And so I wanted to see what your opinion was on, is there a place for white rice in the diet of diabetics patients? How would you
Yes,
advise on that?
yes, I do think that there is a place. So, does rice consumption increase the risk for diabetes? The answer is yes. Okay, so there have
Right.
been multiple studies, some of them yes, some of them no. But many of these studies are done, of course, almost all of these studies are done in Asians. Okay, so where
Hmm.
there is, and if you have a population where everybody smokes, smoking will never come out as a risk factor for lung cancer. Okay,
Right.
so much the same way. Okay, so these are just cross-sectional epidemiological studies. So I won't there's only so much you can do.
Right.
It's impossible to do a randomized control trial over a long period of time where you can have
Right.
some people on rice, some people not on rice. Okay. But yes, so whatever we have, now what these studies have shown is so when they looked at the quartiles of those who have the highest consumption of rice compared to those who have the lowest consumption of rice, so these people had a higher risk.
Right.
Now, everybody has to eat. It's a zero-sum game. Okay.
Yeah. Yeah.
So who are the people who would have most of their calories coming from rice as opposed to those who are where it is not? Actually, to me, it is actually. So who can afford to eat more vegetables and more proteins
Correct.
as opposed to somebody who has to fill his stomach with just rice?
Right.
So, obviously, so this person who is also eating a lot of vegetables and is likely healthy and richer and more educated. So I think there are other things that also go into it. But yes, so eating more rice will certainly increase your risk for diabetes.
Right.
But does that mean that we should completely give up rice? No, obviously no. And that's not even a feasible thing. Okay. So I don't even think that's how we should look at this.
Right.
It's impossible that tomorrow everybody will say, oh, we're not going to eat rice. Okay.
Yeah.
So that won't happen. So how can we still eat rice and decrease our risk for diabetes? Carbohydrate. So this is what one of my old professors in All India Institute would say. A carbohydrate is known by the company it keeps.
Right.
Okay? So glycemic index, so this glycemic index is such an artificial measure. Okay, so you give 50 grams of that pure food and you look at the glucose excursion and compare it with that 50 grams of white bread, and nobody eats 50 grams of one food. Okay? So I don't think it really means anything. So it really means, how do you eat that? So as long as you eat rice as a part of a mixed meal with adequate amount of fiber and protein, and actually even fat for that matter, you will lower the glycemic index. So the glycemic index of rice is 60, 65, something else is 40. But you will never eat just plain white rice.
Right. Yeah. You have it with things that are associated with the rice. Oftentimes rice is just our vehicle to eat vegetables, to eat dal, sambar, all of those things that contain protein and fiber.
Of course, if you keep eating chitrana all the time, yes, you're
then there's a problem. That's correct. Yeah.
But otherwise, if you eat a traditional rice, a sambar with lots of vegetables.
Right. Okay? Yeah.
And, pulses, and try to eat pulses with basically with the whole pulses.
Right. Okay?
The whole pulses, the
grams.
Skin on.
Right.
That would be good. And same thing with rice as well. Okay. Right. So I think we should have increased the consumption of brown rice. So less processed rice, which probably has to do also with magnesium and other micronutrients which are there in the husk. You obviously know way more, and you should tell us more about those things.
That'll be another day.
That will be another day. So you should do that. So anyway, the bottom line is, yes. So eating a lot of rice is not good. But that doesn't mean we should not eat rice. We should be smart about it. Okay? Right. So we should probably eat rice, but eat it with lots of high protein and high vegetable. As long as you do that as part of that, I think rice is fine.
So now, the other thing that, sorry, go ahead.
People, that it's horses for courses. So there are so what do you eat instead? Okay, you can't not eat anything. Okay. So somebody actually did a study like that. So if you, instead of rice, if you substitute it with noodles and things like that, so it makes it much worse. If you substitute it with high fat food, it makes it much worse.
Right.
Wheat. So that's what most of us do. So we end up actually, instead of rice, we eat wheat. But then again, it depends what kind of wheat. So whole wheat is, yes, good. But then if you're going to eat maida chapatis, I don't think that's any better.
Right.
And there are some people who have gluten insensitivity.
Right.
So there are many quote unquote experts who go around saying, oh, gluten is the worst culprit. It's bad for this, that. And so if you eat that, it is bad. I don't think it's, for not centuries, millions of years, people have grown up. Humanity has flourished eating rice and wheat. Okay. Right. So I don't think that they are poisons. So yeah, there'll be some people for whom now, if you have type 1 diabetes, okay, so clearly the pure carbs is not good. So you should try to restrict it.
That's right.
And if you are gluten insensitive, you should certainly not eat wheat.
Right. Of course. Yeah.
Otherwise,
Yeah.
in general, whole grams and whole cereals should be part. So the ADA recommends that 50% of our calories should still come from carbohydrates.
Right. And the others are also important. Things like fiber and protein, and you mentioned some fat too is important in our diet. So that
Oh,
kind of
absolutely.
balance, that the advice as far as balanced diet goes, has not really changed. It's something that, yeah. Okay. So the other uh, question I had, and this is a little humorous too for me, is mangoes. Right. So I'm not personally a huge fan of mangoes. But a lot of people that I know that are close to me, they love mangoes, and there are two controversies as far as I know about mangoes. One is which is the best variety of mango. My Maharashtrian wife will swear that it is Hapus, and then that some others will say it's Banganapalli or Ratnagiri or whatever. But that is not the controversy we are here to try and sort out today. Um, in very simple terms, I know there's probably not a
Do
simple
let me
answer
know.
to this.
Once you have sorted it out, do let me know. I
I'll
really want
let
to
you know.
know.
Yeah, it's very difficult to get hapus in America, but that's a different story. So um, th- there's not a simple answer to this. Are mangoes good, bad, or neutral?
Oh, they are good, of course. Why would you even ask a question
From
like
a diabetes perspective.
that? Well, okay. So, well, does it increase your blood sugars? Yes, if you eat a lot of mangoes, it will. So, does it mean everybody with diabetes should avoid mangoes? No.
No.
Okay. So again, I know people have actually looked at it, and there are some people who will say, oh no, there's nothing wrong with mangoes. If anything, they're good. They will lower your blood sugar. Jackfruits
Right.
lower your blood sugar.
Right. And you also seen
Papayas
things like
lower
the
your.
vitamins that are in the mangoes, especially have a low blood glucose lowering effect and things like that. So yeah.
Yeah, this glucose lowering effect. So this is interesting. Um, I don't claim to be any expert. I haven't followed this in great detail, but then something very related. So there is a new class of diabetes medications. You might have seen ads on television, okay? Things like Farxiga, Jardians. So there
It's
is
like
this new class of,
semaglutide.
no, not semaglutide. This is
Okay.
something else. This is a
Something
pill,
else. Okay.
okay? So it
Okay.
basically makes you pee all the sugars out. It increases glucose excretion in the urine. Yeah?
Okay.
They're called SGLT2 inhibitors. So this is the big fad now, okay? It's supposed to be good for heart, kidney, all of these things.
Hmm.
But you know where this thing came from. So there is this, so the apples have this thing called fluorescein. And fluorescein was known like way back in the 1800s. So they got this from the bark of apple trees and also in the apple peel and so on. So this causes glycosuria. So you just spill
Right.
the glucose. Of course, at that time, they were only using it because they wanted to look for some anti-malarial thing. And then they
Okay.
identified fluorescein. But then they found that it also causes glycosuria. But nobody was interested in glycosuria then. It was not an effective anti-malarial, so it fell down. But now, of course, it's been rediscovered as a diabetes drug.
Hmm.
So does that mean that if you can you eat enough apples to get the fluorescein effect? No.
No.
While it is true that there is fluorescein in apples, so I did the math at one time. So you will have to eat something like 60 or 70 apples a day to get the equivalent of one, adequate fluorescein that you can get in one pill. So yes, it is true that they probably have some very useful phytonutrients which can potentially lower your sugar. But can you get that from eating a mango? I don't know, but I doubt very much. Okay,
Right.
I don't
Right.
think so.
Right. So the
That's one.
glucose reducing effect is probably not true, but at the same time, it's not something you must totally avoid if you're a diabetes patient. Again, like you say, be smart about it.
Be smart about it. Maybe eat it with the skin, so you'll get more fiber. So that will temper the glycemic
Right.
excursions, and moderation, of course. Okay,
Moderation. Yeah.
so
Yeah. So
moderation and this thing. So, and the mango that you like the most is the best mango. Clearly,
that's
okay.
clearly the best
What
mango.
keeps
You're
you
right. Yeah.
happy? Yes, I mean,
Yeah.
The
Yeah.
frustration of avoiding a mango will probably raise your blood sugar way more and then the actual glycemic load in the mango.
Wow,
And
that's
as
yeah,
long
that's
as
a
you eat
great
it
way.
as part of a meal, so the problem that most of us do is we have a heavy meal, and at the end of
Mhm.
the heavy meal, then we eat a dessert and a mango and something.
Correct. Correct.
So yeah, I guess that will be additional thing. So yeah, while I don't know all these specifics and the details, I would
Right.
hazard a
But you
guess that
highly doubt that they have any beneficial effects towards lowering blood sugar.
I
Mango. Yeah.
don't know that. I don't know
Yeah.
if anybody has done I know they've done studies with extracts.
Right.
Okay.
No,
So
that's
these
different.
extracts are very different
Right.
from an actual mango. Okay. I don't
Correct.
know if anybody has ever shown that if you eat a slice of mango, your blood sugar goes down.
Goes down. Yeah, that's right.
So I
So
don't know whether that's true.
yeah, so these are the kinds of things that show up on your internet feeds and I think social media feeds,
Mhm.
and we sometimes instinctively uh, want to believe those because we love mangoes so much that we want to believe that it is good for diabetes, but really uh, it's not about good or bad. It's
I mean,
about
does it
yeah,
have good things? Absolutely.
right,
Okay.
yeah,
So
yeah,
many good things in the mango. But then also there's a lot of fructose in it.
fructose. That's
Okay,
right.
and we
That's
know
right.
that
Yeah,
now the fructose in fruits is fine simply because the amount of fructose there, we know high fructose corn syrup is metabolic poison. Okay, so that's
yeah,
bad.
yeah.
But then, yes, so I mean, mangoes also have fructose, so too much fructose is also not good. So if you want to get all the good things in mango from a mango itself, but I think it's packaged so beautifully. Okay, so as
Yeah.
long as we eat the whole mango and in moderation, I think we are fine, including people with
With
diabetes.
diabetes. Okay, I think that will be gratifying for a lot of us to know. So um, you've shared so much with us, and this has been a great time that I have had learning so much about diabetes and how to manage and so on. If there were three things that you want everybody who watch this to sort of leave with in terms of diabetes management, what might they be?
Well, one I've been saying again and again. Okay, so you can't be very glucose centric about it. Okay, so it's not just about chasing a glucose number.
Mhm.
So diabetes is a comprehensive metabolic disorder. And so when you look at it, it must be a comprehensive management strategy as well. And so people with diabetes should not just look at the sugars, but also lots of other things. And I
Okay.
think the foundations of everything is a healthy lifestyle,
Okay.
regular exercise. I tell all my patients, I said, 150 minutes a week and so on. So I tell my patients, oh no, it's very simple. You just need to exercise on the days that you eat. Okay. So it is,
Yeah.
unless we do that, okay. So
Right. Yeah.
without regular, I can see that when we were children, I used to come to your house and play on the street,
That's
and
right. Yeah.
we used to walk, okay, a mile every day and never thought that it was anything different.
Yeah, or run after the BTS bus before it left us,
Run
then
off,
the next one
yes.
won't come for 2 hours. So yeah,
Right. And so I
yeah,
never bothered what I was eating or everything, and we were fine. Of course, we were younger too, but
sure,
overall, but now people don't do that. Okay. So this day-to-day activity, prolonged sitting, okay, and very little physical activity when it comes to regular work schedule. So we have to make time to
correct,
exercise.
correct.
So if on the other hand, if we can get off sedentary habits, keep ourselves, this adage about sitting is the new smoking, okay.
Right, right,
So regular, I mean, but sometimes you can't help it, okay. No, but then at least it can be overcome by regular physical exercise. I think physical fitness. So, there's a lot of thing about fitness and fatness, okay? That, it's more important to be fit and not worry about how fat you are and
got it.
all this. And there's a lot of data on that. You must have a podcast on that, okay? Fit but fat, okay? So that's an extremely,
Fit but fat. Okay, yeah,
yes, yes. So that's a thing, okay? So don't worry whether you're fat. Try to be fit, okay? So physical fitness is very important. So physical fitness, regular exercise, and as you said, the diet. So there is no one excellent diet. Okay. So it's really the one diet that you can stick to.
right.
Okay. And that's it. So this is not a sprint, it's a marathon, it's something. So Do ketogenic diets help? Yes, they do. Are they bad in some? Yes, they are. Can you sustain it for long periods? Probably not. Okay.
Right. Right.
So therefore, just like any, it must be a balanced diet, and it should be something you can do for a long period of time. So lifestyle is the most important thing. And then I think if there is one other thing I should probably say is, again, there was a trial called the Steno 2 trial. It was done in some Norwegian countries. So where they, most of the, again, diabetes is not about treating glucose. It's about preventing heart disease more than anything else.
Right. Okay.
So what they showed was that when you have a multifactorial approach where you simultaneously looked at smoking cessation, weight, blood pressure, cholesterol, as opposed to just simply glucose, you were able to bend the curve, decrease the risk of heart disease and so on. So you can't
Right.
just be obsessed with glucose numbers. So it's in the
Got it.
broader context of, at the same time, you should also look at cholesterol and blood pressure and all of these things. So while I know there is a lot of thing about people are pushing medications and there is polypharmacy, and
Mm-hmm.
it may be true, but then it is also true that judicious use of medications has been quite convincingly shown to reduce the risk of heart disease.
Got it. That's right.
And when
So,
appropriate, I think we must not shy away from medications.
right.
For the first option, but for many of us, medications are not a bad choice. And it is
Right.
never lifestyle or medication. So after a point, it will be lifestyle plus medication. So it's still the cornerstone lifestyle, but then judicious use of medications, I think we should not just shy away from
Shy
them.
away. That's right. So that brings me to probably the last point, and that is, how would you encourage people to find good information? Because we cannot ask people to completely avoid the internet. It is a very helpful resource for all of us to find good information. But what are some strategies that you might advise we use to separate the wheat from the husk, or the um, yeah.
I don't know. We all live in our own echo chambers, so who knows? Okay.
Yeah.
Yeah, obviously, look for some reliable sources. If you want to know about diabetes, go to the ADA website.
So
Now,
ADA is the American Diabetes Association.
American, so the
Okay.
diabetes.org, so they
Right.
have some excellent patient
Wonderful.
information. ICMR has excellent nutritional
Right.
resources.
So this is the Indian Council for Medical
Indian Council
Research.
for Medical Research.
Right.
I
So
think there is also something called IDSS or something, Indian Diabetes Research. There are, try
right.
to, in general, what appears boring is probably right.
It's probably right.
Okay.
And that's I think the
So,
greatest piece of advice. What appears boring is generally right. So I think that is something we can all take with us. So thank you very much, Vinay. This has
uh,
been a very enjoyable conversation and very educational and informative. And I hope that whoever watches this will be able to take solace in the idea that moderation, lifestyle changes, and judicious use of medications would all work together to help them manage their diabetes. And so I'm very grateful to you for taking the time to do this.
thank you, Karthik. Oh, it's been an absolute pleasure
Okay.
talking to you again. Okay.
If you will hang on for just 1 second, well, actually, take a little longer. I just want to do a little add-on just for our Jolly group. So I'll edit the original, this recording, so that it's 2 parts. And what I want to do for Jolly Group is just this. Hopefully my daughter figures out a way to edit all this out. And I just had this verse in Kannada that I found that I felt was very apt for what we are doing today. So I just want to read it out here. And my Kannada is obviously not the greatest, but I'll do what I can here. So ನಮಗೆ ಯಾರು ಕೆಟ್ಟದನ್ನು ಮಾಡಿದರೆ ಅದು ಅವರ ಕರ್ಮ. ನಾವು ಯಾರಿಗೂ ಕೆಟ್ಟದನ್ನು ಬಯಸದೇ ಇರುವುದು ನಮ್ಮ ಧರ್ಮ. ಅಜ್ಞಾನದಿಂದ ಅಹಂಕಾರ ಬಂದರೆ ಅದು ವಿಷಕ್ಕೆ ಸಮಾನ. ಅದೇ ಜ್ಞಾನದಿಂದ ವಿನಯ ಬಂದರೆ adu amritakke samana. So I thought that was very apt for our conversation today. I just wanted to make sure that I shared that with everybody. So thank you once again. It's an honor to be connected to you, and to tell people that I've grown up with Dr.
Oh, no,
Vinaya
no,
Simha,
no.
and so yeah, and it's been great. So thank you very much.
It's been great being part of the jolly group. That's all we should we should leave it there. Okay.
Yeah, that's right. So